Hi, y'all, and welcome back to Professor Truelove's Concepts for Nurses series. And this is Professor Terry Truelove. In this episode, part of the Cardiac Concepts episodes, we will continue our discussion on ventricular rhythms in Ventricular Rhythms Part 2, where we will look at such rhythms as ventricular tachycardia, Torsade du Pointes, and ventricular fibrillation. Sources for this episode include Cohn's Flip&See ECG, 4th edition. Thinking about the first episode of ventricular dysrhythmias, you should recall that ventricular rhythms occur when the other pacemakers are destroyed or disabled. Further, you should recall that the normal rate of the ventricles is between 20 and 40 beats per minute, and that rates between 41 and 100 beats per minute are called an accelerated idioventricular rhythm because rates over 100 are what is called ventricular tachycardia. So rates between 101 and 250 beats per minute equal ventricular tachycardia. Ventricular tachycardia is significant because of its unpredictability and potential to cause death. A patient may be stable with a normal pulse and adequate hemodynamics, or they may be unstable with hypotension and no detectable pulse. Because of reduced ventricular filling time and the drop in cardiac output, the patient's condition can quickly deteriorate to ventricular fibrillation and then complete cardiac collapse. The source of ventricular tachycardia is usually increased myocardial irritability caused by things such as myocardial ischemia, myocardial infarction, coronary artery disease, valvular heart disease, heart failure, cardiomyopathy, electrolyte imbalances such as hypokalemia, drug intoxication from medications such as digoxin, procainamide, quinidine, or cocaine, and the pro-arrhythmic effects of some of the anti-dysrhythmics given for this very purpose. In many conditions, ventricular tachycardia is an absolutely lethal arrhythmia. It is life-threatening because, in those cases, the ventricles are not filling with blood, so there is no cardiac output and no discernible pulse. It is a pulseless emergency. Key waves seen will not be from the ventricular tachycardia, and if they are, they will be a retrograde. They may be part of the underlying rhythm. Also, the QRS complexes are greater than 0.12 seconds and bizarre. If ventricular tachycardia is seen on a monitor, the patient must be immediately evaluated, and you should be prepared to call a medical emergency, a code. If the ventricular tachycardia lasts less than 30 seconds, you can refer to it as a run of V-Tach or unsustained V-Tach. However, a greater than 30-second run is known as sustained ventricular tachycardia. This is an example of ventricular tachycardia, in this case, monomorphic ventricular tachycardia, as seen not only from a single lead, but also in a 12-lead EKG configuration. Note the wide and bizarre-looking QRS complexes with no evidence of P waves. Also, notice the heart rate greater than 100 beats per minute. Compare the monomorphic ventricular tachycardia to another type called polymorphic ventricular tachycardia. In this case, this represents Torsade du Pointes, or twisted ribbon. Torsade du Pointes is a polymorphic VT, and it looks like VT, but it is unclear if it is from a single or from multiple sites. The amplitude increases from nearly baseline to very large, and then back down again. It starts suddenly and is frequently preceded by a prolonged R to R interval. It is life-threatening, but has a different treatment than monomorphic ventricular tachycardia, and therefore must be properly identified in order to treat it with the proper medications. Treatment guidelines for ventricular tachycardia are based on the patient's hemodynamic status. Those patients with unstable hemodynamics will be treated accordingly, whether they are treated under the pulseless category of ACLS protocol or if they are treated as ventricular tachycardia with a pulse. In other words, a tachycardic algorithm. So while the treatment of a monomorphic ventricular tachycardia is to administer epinephrine, antidysrhythmics such as amiodarone, and defibrillation, the treatment for polymorphic, such as Torsade du Pointes, includes medications such as isoproterenol, magnesium sulfate, and even cardiac pacing. The other lethal ventricular arrhythmia is ventricular fibrillation, commonly called V-Fib, which is a chaotic pattern of electrical activity in the ventricles in which electrical impulses arise from many different foci. It produces no effective muscular contraction and no cardiac output. This is because within the ventricles, there are now impulses originating from many different areas. So there is no organized activity at all in the ventricles. The ventricles simply quiver in place. Neither the atria or ventricles depolarize with any organization, so there is no P, no QRS, and no T waves. Instead, you note a wavy and chaotic line which may be coarse or which may be fine. The upper strip is an example of fine ventricular fibrillation, while the lower strip is an example of coarse ventricular fibrillation. Untreated ventricular fibrillation causes most cases of sudden cardiac death in people outside of the hospital. There are a number of different reasons why a patient will develop this potentially lethal arrhythmia, and they include myocardial ischemia, myocardial infarction, untreated ventricular tachycardia, heart disease, acid-base imbalances, electrolyte imbalances, an electric shock, severe hypothermia, drug toxicity, and severe hypoxia. The rhythm itself is not what should be treated. Instead, treat the patient's hemodynamic status, whether they are suffering from a tachyarrhythmia or a pulseless arrhythmia will dictate the ACLS algorithm that you should choose. Another pulseless rhythm of concern is asystole, or ventricular standstill. In ventricular standstill, there is no ventricular mechanical activity. Therefore, there are no P, Q, R, S, and T waves. However, the rhythm may be slightly wavy and look like fine V-Fib. Check that in more than one lead. And as you might imagine, this is a lethal arrhythmia, and it must be treated according to your patient's hemodynamic status. Treat it as a pulseless dysrhythmia. In some cases, the monitor or rhythm strip may show what looks like an otherwise normal ECG tracing, yet when the patient is checked, they are pulseless, non-responsive, and are in full cardiopulmonary arrest. When this happens, this is known as pulseless electrical activity, or PEA. So in this case, the electrical component of the heart looks normal, but there is no mechanical activity. This patient should also be treated under the algorithm for a pulseless cardiac rhythm, as laid down by ACLS protocol. That does conclude this episode concerning ventricular rhythms, but there is one more episode, and we'll talk about ST segment changes in that episode. Until then, I hope you learned a little bit today. I hope you come back, and if you do, we'll see you then.